Well, hello everybody. Thank you for joining RX Site Ed, an educational series brought to you by RX Site. It's a session on light adjustable learnings, ways for you to implement new technology into your practice, such as the light adjustable lens. Now, I'm here with a friend of mine, Dr. Priya Desai, who we'll introduce in just a minute. But I thought I'd let you know I'm Matt Jensen. Was an administrator of Vance Thompson Vision, the CEO there for 20 years, and have since been really working in the industry and in practices to help them implement new technologies. And that's why I'm so excited to be part of these discussions, is because the idea of technology transfer from the idea that the industry has to the doctors who make it work in real time to the implementation in the practice, it's not as easy as it might sound. And so we can help people learn through sessions just like this. Now, Dr. Desai, you and I have been talking leading up to this, and I'm eager to have you share with our audience a little bit about your practice and and how you specialize in the refractive, what I call the refractive cataract space.
Yeah, sure. Well, thank you. Thanks for having me. I'm Priya Desai. I am a glaucoma trained specialist. I'm from Southern California. I did all my training out at UCLA, and have relocated to the wonderful Garden State of New Jersey. I see patients both on the New Jersey side, and also on the Pennsylvania side. So we have offices in both states. I originally got into ophthalmology by joining Matosi and Eye Associates, which was a mid-size multi-specialty ophthalmology group. Now I am part of a much larger group. It's Prism Vision Group. We have about 200 physicians, all ophthalmologists, all various subspecialties. I am also the chief medical officer for that group, still practice clinically. I spread my time, I would say, probably 60% to 70% clinical, and then the rest is my administrative role. Still actively involved in both managing glaucoma and all things cataracts, including some of the premium cataract technologies.
That's great. Well, you have widespread influence, and so I'm eager to hear not only how you've talked about and implemented this technology, but also how your whole program has, because wow, that influence I think affects a lot of different practices and settings. Let's dive right into that. We're talking about the light adjustable lens today, and how and when did you decide to start using the light adjustable lens?
So it started off with the patients, like most things do, I would say. So I had a few patients ask me if I was performing the light adjustable lens implantation and using that technology. And this was a few years ago. The technology was already in the United States, not as widespread as it is now. And after my third or fourth patient request for this technology, we have been in contact with the RX site, and that's how it all started. So the initial impetus wasn't because I wasn't excited about the technology, but really the patient request is what got us off the threshold and jump into the LAL sphere.
Well, that's really that is something I don't hear very often. That's really exciting. Give me an example of what they said to you. How did they present the question to you about whether or not you offered the LAL?
Um, One patient that sticks out, her husband is a primary care physician in the community that I practice in. And so, lots of patient referrals back and forth from his practice to ours. And his wife, who happened to be my patient, came in to see me and had said, hey, my husband went and saw a different physician at one of the teaching institutions nearby and recently had cataract surgery. And he had this new lens implant. That's how she brought it up to me. She was ready for cataract surgery, wanted me to do it since she had been a long-time patient of mine, but wanted to have that technology, meaning the light adjustable lens. At that point, I told her that this was something we were evaluating. We hadn't quite implemented it yet into our practice. And she said, all right, I'll wait. And then a year later, when I started offering the technology, obviously, she was very happy to be one of my first patients that I performed the procedure on.
What a great way to start the program, right? To already have a sense of the patient interest and demand. So you're talking about the evaluation of whether or not to invest in and start doing the light adjustable lens. What goes into that kind of decision making for you as a provider, but also with all of your partners?
Yeah, I mean, like I said, it all starts off with the patient. No matter how big or small we are as far as, organizations, the reason we're in this is because of patient care. We all want to deliver the best, highest quality, most state of the art experience and technologies to our patients. So that is probably the number one criteria and probably the one that holds the most amount of weight. So if this is something that's beneficial to our patients, if this gives our patients something we're not able to offer through other modalities or technologies that we're using, I would say that's when it opens up the discussion of whether we want to use this new technology. Next thing, of course, is, well, how feasible is it to bring into your practice? How much of a learning curve is there? I would say to use the new technology. We in medicine are very used to always learning. If we ever stop learning and start staying still, that means we're moving backwards, right? So learning a new technology is not scary to us. We know that's something we have to continue to do. But there are different steepnesses of the learning curve depending on the technology. So that would be the next thing that we think about in terms of timeline and how quickly we can bring something in. And then, of course, there is the cost and the physical footprint of new equipment, if new equipment's needed for that technology, and then obviously patient flow through the office. So I would say those are probably the main things that we think about. Um, just sorry, I don't want to ramble too much, but so once we realized that this was something that our patients were asking for, we did not offer a similar technology that could take the place of these requests. We knew that this was something we needed to do sooner than later. Being part of a large organization spread across several states, we did pick a few pilot offices to not so much trial the technology, but trial our implementation, trial how we needed to adjust our patient flow, communication, education of patients, all those things. And so we did pick two practice locations within Prism Vision Group where we started trialing the light adjustable lenses and really learned what we could do better in terms of onboarding our staff, our physicians, educating patients, how we needed to adjust certain things in clinic flow, and then we were able to expand it throughout the organization.
Okay, so first of all, what an awesome way to think, and what a great testimony and story as to how you went about the thought process. So it's kind of, does it benefit patients first? Do we offer something counter to it that could be a reasonable alternative? Is it something that as providers we feel like we can do? Um, is it something we can implement across our whole platform? And then what are the financial implications of doing that
Yep.
in our pro forma for what the return on investment would be? I mean, that I think for as a take-home message to any practice, really discerning any new technology, that's a pretty good flow of like a decision-making tree. Um, so at what point then did you have enough information to expand from two sites to more sites? And how widespread is the technology at Prism right now?
Um, well, first I'll say we want to make this technology available to any surgeon in our organization that wants to offer this to their patients. And we want to make sure that any of our Prism patients, doesn't matter where within the Prism locations, they see our doctors, but the patients have access to it. So we're not 100% there yet, but we are expanding as quickly as we can the technology. Um, I would say we didn't have a hard time frame. We reevaluated at 60 days, reevaluated at 90 days, and right at about that, I would say 4 month period, we knew this was something that we had figured out how to implement, and we started thinking about expanding it. Um, the, I guess the biggest learnings that we had from the pilot offices was number one, setting the price for the technology and educating our patients on the technology. And the second was the logistics of how we incorporate the light delivery treatments, which, as you know, is different than what we're doing for other IOL implants. So those were the two things that we really needed to iron out before we rolled it out to the other practices.
Okay, so this is a great Q&A, Dr. Desai, and I'm eager to get some of the morsels from this decision making. So you've got two sites, and they're rolling out this technology. Sounds like you've got maybe pricing that's different in each of the sites, or maybe you're testing, A/B testing different pricing models. Talk to me about the flow and the efficiency and how you learned what would be the best way to set those things up and how you arrived then at what is now your kind of go-to way to implement this.
So we had a lot of help from the parent company, from RxSite, in terms of determining price. They were able to offer us information about the range of pricing throughout the country, and then more specifically to the regions that we were in. And they really did help guide us in setting a price, looking at what we were already offering. So we didn't do that, we didn't just do trial and error. We definitely had some information that we went off for that. Patient education, again, RxSite has a huge library of material that we could use for patient education, QR code, like things that you could keep in the office for patients, FAQ handouts. And so we were able to use that and tweak that as needed to work with, the branding and stuff for our local practices. And then how we incorporated the extra office visits for the light delivery treatments. We had several surgeons within the two locations offering this technology. We realized that it worked best for us, for both practices, which kind of were trialing this separately and then got together to see, how what commonalities we had in our experience, was for the light delivery treatments to be primarily handled by our optometry colleagues, who we work very closely with anyway. That was pre-existing before the light adjustable lens introduction. So once we decided that, we had to really work on how we message that to the patient, that this was teamwork between the surgeon and the optometrist, how we worked on our clinical templates, schedule templates to accommodate for the light delivery treatment visits, which the lengthiest part of that, I think, is making sure that you have a good dilated eye. You can't take shortcuts on the dilation. And sometimes that just takes longer than the dilation that we would need to do an exam. And so figuring that out, and then identifying how to fit that into a busy, regular clinic. So our optometrists that were primarily doing the light delivery treatments, we worked very closely with them and came up with a good patient flow. We, from the very beginning, work with when we discuss the technology with our patients, put it that way. Hey, look, I do my part, the surgery, I'm the expert at that, and I'm going to be your surgeon. Then all the light delivery treatments goes to our head optometrist, who is very much better qualified than I am to do the refractions and the light delivery treatments. And so the patients know that at the outset, and there's really no issues at all. And so those were the few things that we were working on.
If I may ask, how far into your organization then has the light adjustable lens technology penetrated? How many providers use it, who are eligible to?
So we have I mean, pretty much every single one of our cataract surgeons wants to have access to the technology. And so we're working on that. We are less than a year into the introduction of that into even our pilot practices. And so at this point, we have, I think we have about 8 or 9 offices with more scheduled for the introduction of the LALs. Well, I should say 8 to 9 light delivery treatment devices, which actually supply more than one office. So we do have patients that travel from nearby offices to another office that actually has the device there for their treatments.
Sure. But there is appetite for it, is what you're saying, and people seem to be, at least after a year of implementation, they're bullish.
Yes, we have several requests already to have the technology in offices, and we're working towards it. As you know, you just can't snap your finger and have everything happen overnight, but we're trying to work as quickly as possible. And there is not one office that doesn't want the ability to perform this for their patients.
Great. What was the biggest challenge in your implementation?
Um, it's the how do we say the non-clinical stuff that goes into it. So, being an organization that spreads over various states, we have our administrative and operations team that's really involved in making sure that all the things that need to be done on the back end to incorporate it, from schedule changes to making sure our surgical coordinators are up to speed. We have all the educational material in the offices. Those are the things which we've found a little bit of a bottleneck because you have 1 or 2 operating directors that are in charge of large regions. So that's probably the biggest bottleneck.
And as you're doing this, would you maybe, I'm not going to ask you your pricing, but is where you position the light adjustable lens the same as other premium IOL technology, higher or lower than?
That's a great question, actually, because we talked about that quite a bit as physicians when we were initially rolling this out. We do have relatively uniform pricing throughout our organization, and we all are pricing our light adjustable lens as one of our most costly, I guess you would say, premium options, partly for 2 reasons. First, there is a lot of extra time that you put in, and by a lot, I mean relative speaking to other lenses. Um, After the implantation, we have all these extra visits dedicated towards the light delivery treatment. Patients understand the value of that. So it is so easy for patients to understand why they're paying extra for this. Sometimes I have to work towards explaining the extra cost for the other premium services we do that are not LALs. Because it's a lens that goes in the eye, and the patients wonder, well, why did I pay all this extra money? So for this, actually, I've had patients say, oh, that makes a lot of sense. I'm coming in all of these extra times. I'm working with this other doctor. I'm letting you know how to adjust back and forth. So they see a lot of value in the extra cost. So I actually haven't, me personally, and from discussing with my peers, we have not had the kind of like hesitation from patients or questioning from patients when we discuss the price of this, because we do talk about what the patient can expect, which includes the extra visits for the light delivery treatments.
Dr. Desai, I'm trying to imagine myself as your patient. Tell me how you describe the technology.
Um, I describe it. I went through a couple different routes. I've heard different doctors describe it other ways, which works for them. I usually say it's like buying a suit. You buy the closest fit off the rack, fits you pretty well. But then if you want the little things to be perfect, that's when you take it to the tailor, and you hem this or you tuck this in. And that's pretty much what we do with the light adjustable lens. We get the closest matching lens power for you. And then we can adjust on top of that because all lenses, like shoes or clothes, come in sizes and steps. And up until this point, we have not been able to make any adjustments that aren't one step or the other. But here we can kind of make adjustments in between the steps. And that usually is pretty, descriptive for patients and they understand what I'm talking about.
Yeah, that's a great visual of how to think about it. And you're right. A lot of providers use different examples, so I'm always eager to hear how folks are describing it. Has it been a practice builder for you?
Definitely. I will say that when we first started it in my location, we were one of the few practices in our region that was offering the lens implant. Now, it like if you don't have it, I would say you're probably, on the side of the fewer practices that aren't offering it. So to be, if you're taking the patient's wishes and putting that aside, just to be competitive, I think you have to offer these newer technologies. There are several types of patients which I would not be comfortable doing the, traditional premium implants, multifocals, diffractive lens um, technologies. I would not be comfortable putting those into certain patients. And the LAL obviously allows me a little bit more flexibility to offer some type of premium service for patients that are looking for it that I wasn't comfortable doing other lenses for.
And let's talk about that for a second. What types of patients might not be the best candidate for a traditional fixed lens?
As I mentioned, I'm a glaucoma specialist, so I do see some pretty advanced glaucoma, and with moderate to severe glaucoma, you do have a certain amount of contrast sensitivity loss just from the disease. Adding lenses that can further decrease the contrast sensitivity isn't ideal for patients, especially patients that are looking for better, night vision or vision under dimmer light. So those are like the largest group of patients that I see that I usually excludes that the disease excludes them from being able to get the traditional premium lens technologies.
Got it. And by traditional, you mean those fixed lenses that are the multifocal
Mo-
or
The
toric,
diffractive.
trifocal. Yeah,
Yeah.
diffractive is the right word. Good, thank you.
Hmm.
Okay, so you're walking up to your colleagues at one of our national meetings, and they hear about your implementation, um, and they say, I don't understand why you're doing that. It just takes too long. What do you say to them?
So first of all, I would say it starts with the patient. That's how we really kind of got into this technology. And we're all in this to give our patients the best care. So I know it sounds trite, but that's really the reason that we do everything we do, especially with all the things changing in healthcare. We're still in it because we love treating our patients. So if you think about it with that lens, I mean, speed for anything, whether I'm in the OR or speed when I'm seeing patients in the clinic, should not be the primary factor that rules in or rules out something. Um, as I said, because of our collaboration with our optometry colleagues in our practice, this really has not affected my productivity or efficiency of seeing patients in my practice. Um, so that's number one. I think that if you can as a surgeon, if you can have a colleague who is not a surgeon help you with this, it's better for the patient because that person will spend the time needed, and it helps you do what you're really trained for, which is doing surgery. So that would be my answer. I wouldn't shy away from it due to that. And I think there are ways to make it fit in your clinic schedule to give the patients the technology that they're asking for.
Well, what I hear you saying, and I like that response, is that it's really a patient-driven investment of time, and but it's one where because of the collaborative care, it can really be divided and conquered, right? By
Yeah.
your surgical ability, primary eye care providers' ability to do the light adjustments, and then your teams, walking with the patient through that aftercare period when they're using their vision in their day-to-day living. Well, this is great feedback. And before we kind of jump back on here, I want to also ask, any pushback from the staff? Because it is more work for them, right?
No, I would say no. I think the only pushback was probably from the cost, like, oh, now, now we're, this, how are patients going to afford this? And it's one of those things you learn. You can never make an assumption of what people value, right? Some people are okay with spending money on something and some aren't, and it really depends on what's important for that individual person, and we can't make those judgments. But as far as the extra work for the staff, definitely not. Um, I would say whether we chose the light adjustable lens or any other lens, traditional monofocal, any of the other traditional premiums, the amount of work that our staff does is about the same. We do this all the same biometry and pre-op measurements, all the same routine and how we might refract a patient before okaying cataract surgery. So I would say no, except the putting dilation drops in. There wasn't that much extra work for our staff.
That's excellent. I want to also just tee up the conversation that we'll have about pricing, because it seems to me, in my experience, that this is the first time where actually the pricing is easier to justify. Patients understand that
Yeah,
they get to participate in their vision, and so that they're paying a premium almost feels like it justifies their role in it. Talk to me about that
100%.
a little bit. Can you talk about the customization and them feeling a part of it?
Yeah, I mean, I would say that I've have much fewer, if any at all, comments from patients about like, oh, I thought I was going to get this, but I ended up, or I didn't get as much of this as I wanted, which you do get with other lens implants because it's hard to know what a patient really is thinking even though you try to set expectations. And with this technology, I mean, the patients are the ones that are guiding us and letting us know when they're happy. Well, okay, we're done with adjustments, right? So the patients really love to have that input, especially after they know how they're seeing with, the first step. So patients love it. The one thing I'll say is sometimes patients get a little nervous, like, oh, how am I going to know? And that's where the conversations from our optometrist who does this primarily for all the surgeons, he's great at setting the patient up to know like how to or how to tease the information out of the patient's comments on which way to go with the treatment.
That's great. And I just want to thank everybody for logging on and listening to RX Site Ed, an educational series about the light adjustable lens implementation. It's light adjustable learnings. And with that, we'll adjourn our conversation.